have nothing to disclose. I'm Dr. Alex Falvo from Geisinger Surgical Institute in Danville, Pennsylvania, and today I'll be discussing the outcomes of Roux-En-Y gastric bypass with concomitant cholecystectomy and Mbsaqip 3-year analysis. There are several known risk factors for gallstone formation in the general public, such as age, female gender, obesity, and parity. One well-known risk factor for the development of gallstones and subsequent biliary disease is the period of rapid weight loss found in the first 3 years after a Roux-En-Y gastric bypass, where the incidence of gallstone formation is as high as 38%. Previously, management of the gallbladder during Roux-En-Y gastric bypass was controversial. There was inconsistent data on the level of risk associated with doing a cholecystectomy concomitantly versus before or after the procedure. The largest to date study in Mbsaqip, Dorman et al., noted increased risk, where Wood et al. And Mbsaqip 1-year data noted no increased risk. Theoretically, a laparoscopic cholecystectomy after laparoscopic Roux-En-Y gastric bypass may be complicated by the need for advanced GI procedures to assist with things like ERCP, adhesions, or other technical challenges. Recently, the ASMBS Foregut Committee put out recommendations considering concomitant cholecystectomy, and they stated that they do not recommend routine concomitant cholecystectomies at the time of Roux-En-Y gastric bypass, only if patients are symptomatic. And additionally, no prior studies have looked at minimally invasive techniques and approaches to Roux-En-Y gastric bypass with concomitant cholecystectomy. The objectives of our study was to use the Mbsaqip database to compare 30-day outcomes of patients who underwent minimally invasive Roux-En-Y gastric bypass with and without concomitant cholecystectomy. A secondary outcome was to compare minimally invasive approaches, laparoscopic versus robotic techniques. Prior to beginning our study, we were deemed IRB exempt. The Mbsaqip databases from years 2015, 16, and 17 were queried, utilizing CPT codes representing Roux-En-Y gastric bypass and cholecystectomy using both laparoscopic and robotic techniques. These cohorts were then propensity matched in a 10-to-1 fashion with and without concomitant cholecystectomy. A statistical analysis was done utilizing chi-squared, Fisher's exact, and Wilcoxon rank sum testing. Patients were excluded if they had emergent cases, conversions to open, or were aged less than 18. And a secondary cohort were compared using laparoscopic versus robotic techniques of minimally invasive Roux-En-Y gastric bypass with concomitant cholecystectomy. Our results demonstrate that when comparing minimally invasive Roux-En-Y gastric bypass with concomitant cholecystectomy versus minimally invasive Roux-En-Y gastric bypass alone, the operative time and length of stay were both higher in the concomitant cholecystectomy group. Surprisingly, readmission, reoperation, intervention, complication, and mortality were not different between the two groups. When comparing technical approaches to minimally invasive Roux-En-Y gastric bypass with concomitant cholecystectomy, we found that only operative time was statistically significantly different, and the operative time in robotic cases was longer. Length of stay, readmission, reoperation, intervention, any complication, and mortality was the same between both groups. In discussion, we believe that the current ASMBS recommendations on concomitant cholecystectomy during Roux-En-Y gastric bypass were based on artificially low incidence of biliary disease and increased morbidity of an interval cholecystectomy. Additionally, most studies only had 1 to 2 year follow-up. We believe that by using the Mbsaqip database, we have several advantages over the prior Mbsaqip study. Mbsaqip only relies on random patient sampling, whereas Mbsaqip centers are required to follow patients for 1 year, so admissions and procedures performed at other institutions should be captured and reporting during routine follow-up. While the optimal technique for minimally invasive Roux-En-Y gastric bypass with concomitant cholecystectomy has not been previously studied. Robotic cholecystectomy alone has previously demonstrated an overall higher complication rate. In our study, we found the robotic platform to be just as safe as laparoscopic, but with a longer operative time. And though we did not look at cost in our study, prior studies have demonstrated an increased cost associated with the robotic platform. There were limitations to our study. This is a retrospective review of a prospectively maintained database with inherent observer and reporter biases. Additionally, the Mbsaqip database does not collect information regarding the preoperative biliary symptoms of a patient and does not collect information regarding clinical decision-making on selection of technical approach to surgery. Finally, we are limited to 30-day outcomes. So in conclusion, this is the largest and most comprehensive study comparing the 30-day outcomes of minimally invasive Roux-En-Y gastric bypass with concomitant cholecystectomy versus minimally invasive Roux-En-Y gastric bypass alone. Concomitant cholecystectomy has been proven to be safe in this study with minimal impact to morbidity, mortality, readmissions, or interventions. And finally, 30-day outcomes of laparoscopic and robotic platforms are equivalent, though the robotic platform does have a statistically significant longer operative time. And as always, though they are equivalently safe, there is a concern for increased costs when utilizing the robotic platform. Thank you.